EM board bombs.
And we're back. Hey, Briggs, good to see you again.
Good to see you too. It's a pleasure.
Long time no see.
I know, right?
Just kidding. Saw each other in person.
Reunited. It felt so good.
I can't believe it was like less than a week.
It is crazy. It
Right.
was such a whirlwind we had.
It was
At
a complete
SAM.
whirlwind.
Yeah.
At SAM and
Yeah.
Phoenix and
Yeah.
climbing the second tallest peak in the greater Phoenix area.
Yes, correctly.
That was a lot of fun.
Yeah.
Yeah. So to those who don't know, we met up at SAM. A lot of fun.
Mhm.
We got the crew back together. Unfortunately, we didn't record a podcast. We
No,
had
we
so
didn't.
many different things.
Too
that
much
we were
wind on
doing.
the top of the mountain.
There was. We were having too much fun. Just, scaling thousands and thousands of feet.
Yes. We had to take oxygen tanks.
Oh, yeah. No, we didn't.
Yes. It was very high.
Hey, Briggs, let's just get into this question.
Hey, we got to shout out to our sponsor though.
No, let's get into the
EM
question
News.
first.
EM News. EM News.
EM News. We'll get to you in
EM
a second.
News.
Hey, a 55-year-old male with poorly controlled diabetes presents to the ED with the chief complaint of an allergic reaction. He states that he was diagnosed with an ear infection a week ago, and he's been taking antibiotic drops that he's been putting inside his ear. His pain has worsened, and he states that there's foul-smelling discharge from his ear. He's upset because he thinks he's having an allergic reaction to the antibiotics. And he feels that if the doctor he saw before had just listened and heard him out, his suggestion was just garlic oil that he looked up on Reddit. And he feels like this could all have been avoided if the doctor had just listened to him and just let him take the garlic oil. Then he goes on a tangent about antibacterial properties of garlic and its history in Egyptian, Babylonian, Greeks, and other cultures, and tells you how you really should be learning more from Reddit. While he's doing this, you look at his ear, and you notice an endematous auricle with drainage, significant erythema surrounding, and significant tenderness in the region between the mastoid tip and the mandibular ramus. You also notice granulation tissue at the junction of the external auditory canal. You look at his vitals, he's febrile, he's tachycardic, and the rest of his vitals are within normal limits. What's the next best step? Is it A, support the patient and tell him to use garlic oil as an otic drop? B, initiate oral ciprofloxacin, 750 milligrams BID for 6 to 8 weeks. C, IV ciprofloxacin and admission. D, Zosyn and vancomycin with admission. Or E, CT of the maxillofacial region with IV contrast. Briggs, before you get into the answer, shout out to, now get into
Reddit.
it, our sponsor. Oh, no, our sponsor. EM News. Hey, EM News is
EM News.
awesome. Sign
is
up.
awesome.
You get newsletters. They support emergency medicine in general. Great people. Check it out. Great articles. Some written by yours truly, Dr. Briggs.
Who, me?
Oh, stop it. Hey, what's the right answer here?
Well, after you try garlic oil. Just kidding. Correct answer is going to be choice C, IV ciprofloxacin and admission.
What about the combo? It's not
Zvosin. Yeah.
Zvosin.
No, I knew you were going to say that. It's not Vosin today.
I love how you bring it together, the
Yes.
two.
Oh yeah. You have to.
There should be an epic order for that.
It's called the send it orders.
Send
it. Vosin.
Oh man, so what's going on here, Briggs?
Yeah, we got this guy here with Malignant Otitis Externa, also called Mo. Welcome to Mo's.
Sometimes necrotizing.
Yeah, MOE.
Yeah.
This is a scary one, but an easy one. I think this is actually quite easy.
Yeah.
You know, it's funny because I feel like we cover so much on board bombs, and so many other podcasts out there too say you have to really think of this. If you don't think about it, you're going to miss it. High index of clinical suspicion.
Yeah.
This one, thankfully, usually is so narrow spectrum. You shouldn't miss this.
Yeah.
And that's because there's 3 fast facts here. And honestly, if you're on a time crunch and you're like, listen, I love you guys, but I got a very short commute today,
Yeah.
and I need to catch up another podcast, or I need to
Yeah.
call my family member, or I need to walk the dog, and it's a quick walk.
And you know what
here
other
are your fast
podcasts they
facts.
could be? Wait, you know what podcast they could be catching up with to get those fast facts?
Oh my god, the segue.
I love it. Look at that segue. EM Rapid Bombs. Go to emrapidbombs.supercast.com.
Oh my gosh.
Or just go to
We didn't plan this, ladies and gentlemen.
I know, right? Go to emboardbombs.com and you'll see our question bank that's there. More than 400 questions now and counting.
440.
You get, emails dropped.
As of this week.
Multiple emails dropped a week, and you also get podcasts dropped throughout the month.
Yeah.
It's updated throughout the month. It's pretty awesome. Check it out. 5-minute long or shorter. I would say 5 minutes or shorter.
2 to 4 minutes.
Sometimes they're even shorter.
Some are a little
just
meaty.
Quick pearls that you'll get. Yeah. We got great feedback, by the way, at SAEM on the pod. It's pretty awesome. We had so many folks coming
That's
up
awesome.
and basically saying, hey, thanks for everything you do.
Keep up the good
I
work.
loved listening. Yeah, I know. And in particular, they were just like, it's fascinating to hear like where people listen to it. Some people are like, it's always like walking the dog, going to the gym,
doing something.
Yeah, they're always doing something. It's never like, just this. They're like
all these great optimizers out there. I could be best friends with them. I'm an optimizer
they really
myself.
are, and they just like crush through it. They're like, I just love how I can learn like 5 things in like less than like 15 minutes. I'm like, that's true.
Exactly right. Just optimizers. People really think we planned that segue right there. Do we look like people that have a plan? Let's be honest. Let's be honest.
No, not at all.
It's like that scene from the. It's like that scene from The Dark Knight. Remember the Joker? He's like, "Do I look like a guy who has a plan?" Hey, so anyway, these fast facts that I was leading myself into here. If you want to just turn off the podcast after this, we don't want you to. But here's just the 3.
But we're okay with that. We're secure enough that we're okay with you just turning it off. Honestly, we have enough listeners too.
We have enough self-esteem. So, fact number 1: 95% of cases are caused by Pseudomonas.
Yeah.
Boom. That's your antibiotic coverage right there.
95%.
That's insane,
dude.
We're in sync. Number 2: the major pathophysiology has to do with diabetes, glucose intolerance, insulin resistance, diabetes, aka every single one of these patients will be a diabetic or immunocompromised.
Right.
So on that thread, the third fact is think greater than 50 years old, diabetes or immunocompromised. That's it. That coming with some type of ear pain and swelling. Got to think about malignant otitis externa. Yeah. Okay, now we can delve into some of the details, but that's really the summary right here. Pseudomonas, diabetes. You could do a haiku.
Sorry, go ahead.
You could do a haiku on this. I'm going to work on that. Go ahead.
Well, I was just going to add too, more than 95% of the time, again, you're looking at Pseudomonas, and if they drop something like the granulation tissue at the junction of the external auditory canal, that's almost like pathognomonic for Pseudomonas. Again, the presentation, it's usually pretty dramatic. We gave you a pretty dramatic presentation. They're going to have ear pain. Yes, a lot of ear pain. They might have drainage coming from that ear. And oftentimes it's because they've already started with otic drops, and those otic drops just aren't working, unfortunately. Remember, this is not going to look like your typical otitis externa. This is not just a little bit of swelling inside the canal. This is significant edema. That's why when folks will say, oh yeah, it looks like they have otitis externa, there's a little bit of swelling around the canal, and they're like, oh, but that's a little bit of mastoid tenderness. Okay, hold your horses there. Yeah,
slow down, cowboy.
There. Yeah, exactly. Remember that granulation tissue that we talked about too, oftentimes pathognomonic for Pseudomonas. And again, important to know that because the antibiotics, you will be tested on this because again, 95% of the time caused by Pseudomonas. You're not doing like the big guns that we talked about.
It's also antibiotics that you feel uncomfortable giving.
Yeah,
because
right. you're kind of
feel a little dirty giving them because you're like, oh, I don't like this one.
Yeah,
but that's unfortunately the treatment.
Like IV Cipro, like what?
Yeah, aka fluoroquinolones.
One of the key things, though, again, to take into account is these folks can actually present with cranial nerve palsies, which is the most common one, Briggs.
Obviously, Bell's palsy.
Boom, yeah. So you're talking about like...
There could be other ones, but that's the most important.
So, boom. Yeah.
Again, always the importance, if you have Bell's palsy, you should always do an ear exam.
Look in the ear.
Always do an ear exam. Yeah.
So lab work, getting ESR, CRP, super helpful.
You forgot
a number of times.
You forgot the lactate.
I know. The number of times I see that ESR, I'm like, what am I going to do with this?
I haven't ordered ESR and CRP in maybe 2 years.
Yeah,
I just
no,
stopped
this-
doing it because I was
yeah.
just sick of getting dumb values like that.
Yeah, like what are we doing with this? I mean, the inpatient
Nothing.
team, they're more than happy to order it to trend certain things.
Sure,
That's
it's
fine.
great.
But like, what am I doing in the ER with that if I'm
No.
going to be potentially discharging a patient? This one, obviously, we're not discharging. We'll get into it. Why?
Yeah.
Again, lab work non-specific sometimes can help. If there is a significant leukocytosis or something like that, maybe it tips you one way or the other. And obviously, if the patient's febrile. Cultures of the ear drainage and that granulation tissue, sure. I mean, you can
Knock
potentially
yourself out.
do that. But at the same time, you should know just from an epi standpoint what pseudomonas, right?
Yeah.
And imaging. So this is the other key thing. One of the questions was imaging. I think a lot of folks might have thought, oh, imaging is going to help here. I cannot emphasize this enough. This is huge. Like, this is honestly like this should be like in
choosing
huge
wisely
caps here.
Yeah.
Huge caps here.
Yeah.
Imaging is not going to be making your diagnosis here. This is a clinical thing. The radiologist should not be telling you, oh, consider malignant otitis.
But they don't. That's the thing.
Yeah,
they don't.
Yeah. Don't. Yeah. It is, again, you might on imaging see bony erosion into the mastoid. And also, instead of CT, really MRI is going to be a lot more sensitive at diagnosing this. But this, at the end of the day, is a clinical diagnosis.
Right.
Clinical diagnosis. That means that you should be able to tell just from the history, patient's course, their past medical history as well, and how they look, and on physical exam, like we described, that this person has malignant otitis externa.
Exactly right.
I mean, we basically gave it to you. I mean, on exam, we really did. I mean, endematous ear with the drainage, significant erythema, and then that tenderness in the region between the mastoid and the mandibular ramus, plus that granulation tissue. Yeah. It's laid out for you on a platter. I mean, those are
welcome.
Some of the most, exactly. Those are, and again, they're not going to, on exams, and frankly, kind of in real life, you're not going to see that. Oh, this is a dramatic presentation. So you're not going to see, this is like otitis externa. Maybe this is malignant. No, it's a dramatic presentation, right?
Right, exactly. Hey, so let's talk about antibiotic treatment.
Yep.
So early malignant otitis externa technically can be managed outpatient with a small subset of people. They're well appearing. The ear doesn't look that swollen. It's not completely closed off the canal. There's no drainage. There's no fever. This is very uncommon simply because most patients will delay presentation. They'll think, it's just a ear infection. This is going to go away. Then we get some drops or something from my primary doc or urgent care. And they come in with a pretty gnarly looking ear with some granulation tissue. And if you see any of that stuff, or obviously if they have vital sign abnormalities, and if they have just such a severely uncontrolled glucose, they just need to be admitted, at least for 24-hour OBS. And that's very reasonable. The key antibiotics are always anti-pseudomonal. So get ready to hear a lot of fluoroquinolones. The outpatient treatment, if you were going to do that, the oral ciprofloxacin is the dose here, 750 milligrams BID for, get ready, 6 to 8 weeks. Make sure to tell them not to go on a jog anywhere. Tendon rupture. The inpatient is going to be the same ciprofloxacin, 400 milligrams every 8 hours until clinical response. Now, some of you out there are probably wondering, why do we have to deal with fluoroquinolones if we have beta-lactams and some cephalosporins that treat Pseudomonas? Well, that's a great question. We are really trying to limit the exposure and antibiotic resistance from these antibiotics. And so we're trying to be good stewards here by, yes, fluoroquinolones do have some side effects. And if those side effects are contraindicated in your patient, then you're stuck. You can't use them. But in general, you are only using the big gun beta-lactams when the patient has the following. One, any neurologic symptoms. So we talked about it earlier. So any cranial neuropathy or something, or cranial nerve issue, or significant bony erosion, like they have confirmed mastoiditis or something, even though you shouldn't be getting CT scans. The other is immunocompromised. That's obvious. And then, of course, they have high resistance or contraindications to fluoroquinolones. Significant contraindications. It's not just like, I don't like fluoroquinolones. That's not the right answer.
Right.
And, of course, we're talking, when I say the big guns, I'm talking Zosyn, it's piperacillin, tazobactam, cefepime, ceftazidime, and meropenem. Those are our big guns that we're saving unless the patient looks very severe, very sick, or you have contraindications or resistance to fluoroquinolones. And this is actually not that uncommon. There is a lot of rising resistance, unfortunately, to pseudomonal, pseudomonal resistance to ciprofloxacin. So make sure you look at your hospital's antibiogram, talk to your pharmacist if you have one. Those are very helpable. And that is really it. What else do you have to add?
Really, let's just summarize this. And
I think we already did at the beginning.
Beautiful package.
We already did.
I'm going to ask you a couple key things, and then this is going to be the testable things, right?
Me.
So,
ask me.
All right,
then we got to get to Reddit Corner, though.
Yeah, and we'll get to Reddit Corner after that. All right, so let's bring it in. I'm going to do rapid fire here on ways that this is going to be asked. This is going to be one of our shorts on the social medias. All right, let's do it. Malignant otitis externa, key physical exam findings.
Okay. So it's going to be otalgia, ear drainage, significant redness, and sometimes some significant edema and granulation tissue in the auditory canal.
What is the bacteria that you worry about?
Pseudomonas.
What is the bacteria you worry about?
Pseudomonas.
Last time. What is the bacteria you worry about more than 90% of the time?
Pseudomonas.
Thank you. What is the antibiotic?
Cipro.
What is the antibiotic?
Cipro.
Wonderful. Now, do you admit these patients or do you discharge them?
90% yes.
Yes, and there is a small subset that you can discharge, but usually, oftentimes they have significant risk factors. You're admitting them.
Yes.
Does CT imaging help you make the diagnosis?
No.
Yes, it's a clinical diagnosis. Thank you. That is it. Done. I feel like, these are the only ways this is going to be tested. There literally is no other way you're going to be tested on malignant otitis externa. And now for another corner of Dr. Reddit, read by Dr. Briggs.
Title of this post is Unexplained Ear Pain Not Relieved with Apple AirPods.
So, disclaimer, we do not suggest any of this advice. We simply laugh.
Yeah. We're also not sponsored by Apple AirPods.
Correct. Unfortunately.
Correct. Question. Do you have ear pain like me? I have switched between Dr. Dre's Beats AirPods and Apple AirPods with no relief. I feel sharp pain and itch. The pain also gets triggered when I move TMJ. Feels like an itchy feeling.
Uh-oh.
My ear is 100% clear, according to an ENT. But I believe... I believe he was more of a nose and throat doctor, not an ear, nose, and throat doctor.
No, you're kidding. Do they really say that? Say that again.
I believe he was more of a nose and throat doctor, not an ear, nose, and throat doctor.
Oh my gosh, that's great. Continue.
First comment. I've had this exact same problem. It's brutal. Try putting your earbuds in backwards for a temporary relief.
No.
I don't know if that's going to help.
I don't think so either.
Next comment. I have the same thing going on for 2 years now. Guess what they tried?
Uh-oh. Olive oil?
It may or may not have been the same thing in our questions them.
No, garlic oil.
Garlic oil. Yeah.
They did. I knew it.
Garlic oil. And then another person says, I prefer olive oil. The next person after that says, is it extra virgin or virgin?
No.
I've personally not had a patient come in that has used olive oil in their ear. I don't know if you have. Maybe our listeners have too.
I mean, there is actually some data for, ear wax.
Acetic acid too.
And build up and things like that. But it should not be used to treat malignant.
It sounds like we got a future study in mind.
Let's go.
The benefits of extra virgin or virgin olive oil for the treatment of...
I'm sure that IRB approval is going to be easy.
Yes. They've approved worse. All right, that's all I got. This is getting into TMJ realm. There's a lot of TMJ stuff out there more. That's a new thing coming out.
Yeah, I think we got to be careful.
It's kind of like the...
Yeah, the trigeminal, that is...
That's what I'm saying. There's a lot of overlap between ear pain and that. So I'm saying it's just becoming more common. I don't know. It's interesting.
I don't even want to touch that one. But... Stop.
That's where we're going to end the show today.
We end the show there. So that's another one for myself and Dr. Briggs. Hey, it was so much fun hanging out with you last week.
My pleasure.
We're going to see each other again in a couple months.
Can't wait.
Can't wait. And remember, emrapidbombs.supercast.com, and you can go to emboardbombs.com and click on our question making. Actually sign up now directly from our website.
Do it
Great
this
way
moment.
To support the pod. We appreciate everyone. And again, cannot emphasize this enough. All the folks that came up to me during SAEM, all the folks that said that we helped them with ITE, we helped them just, get better scores. I literally multiple times heard folks say, you guys were a lifesaver for me on ITEs, or I improved so much listening to EM Rapid Bombs on ITE. That was awesome to hear. So we really appreciate it. Even one person even said that they built our podcast into their residency's curriculum, which was so cool. So
That is awesome.
It's always nice to get those. And we actually, I took pictures of some of the folks who came up to me, and it's on our the Twitters. So feel free to check that out, so you can see some of our subscribers. So
Yeah.
much appreciation. Thanks everyone. We're out.
Out. See you later.